the Advanced Clinical Practitioners from the West Essex Virtual Hospital team. And I'm just joining today to tell you a little bit about our service, what we do, and how we can help you with your patients from PAH. So if we can have the next slide, please.
Can you see that all right?
I'm still seeing the first page.
Let me reshare.
Yeah.
Sorry about that.
That's okay. Otherwise, I can share it from my screen if it's easier.
Is that coming up now?
It is now, yeah, lovely. So essentially over at ePut, we have our Care Coordination Centre. This is the centre where all of your referrals come into, they're triaged by our clinical staff and then they're passed down to the relevant services. So under the umbrella of the Care Coordination Centre, we have our community hospitals, so St Margaret's and Saffron Walden. We have our urgent community response teams, so whether that be the occupational therapy response team or the nursing. And we have our bridging services, and we also have our virtual hospital that sits underneath the Care Coordination Centre umbrella. If we go on to the next page, it will be a little bit more about what the virtual hospital actually is. So a definition of what a virtual hospital is a safe, efficient alternative to an NHS bedded care, providing acute care, support and treatment for patients who would otherwise be in a hospital bed. And we're often enabled by digital technologies. So through this, with our particular model, we have two parts of our service. We have the technology-enabled virtual wards, as well as our virtual hospital at home team, where the nurses actually go out and deliver that face-to-face care for patients. If we go on to the next page, please. So when patients come into us, like I say, they normally sit on either side of the virtual hospital, or sometimes a combination of both. So with the remote monitoring patients, for instance, we work with a team called Dockler, and they deliver equipment to patients so that they can monitor their own observations at home. So it will be the blood pressure, the pulse, saturations, temperature, and scales. They monitor their own observations, whether it needs to be done once a day or 4 times a day. And they come up on a dashboard, and that dashboard is reviewed by our ACPs, our nurses and our doctors over at the virtual hospital remote side. And then on top of that, we can also do telephone calls, telephone consultations. We can arrange face-to-face visits if need be. And things such as blood tests we'll organise through the remote side as well. Our face-to-face side, you'll probably be more familiar with. So this is provided by our team who used to be the patient at home team over at PAH. So it's the same team providing the same service, but they've just been lifted and shifted over to ePut now, and working part of the virtual hospital. And they provide with, for instance, the IV fluids, the IV antibiotics in the community, and we provide a lot of supported discharge through this side with patients from PAH. So, like I said, you would already be familiar with that part of the service. There are a couple of changes in terms of how you would refer to us now. So before, we used to have access to the nerve centre and the alertive. At the moment, we currently don't have that. So any referral to either side of the virtual hospital needs to be done through the internet on a referral form. And even if you're not sure what part of the virtual hospital you need to refer to, you can just fill out the same form. We'll triage it and we'll decide from there. So if you go on to the next page, it has our referral criteria for the virtual hospital. So typically some of the things that we respond to, it might be heart failure patients, COPD patients, patients with infections. Our referral criteria is that they must have a West Essex GP. They must have a new score of 4 or less, and the patient themselves must consent to the referral into our service. The team is made up of Different members. So we currently have 2 consultants on our team, with a third one looking to be recruited as well later on this year. We have 3 ACPs, we have our own pharmacists, and we have nurses of all different levels. We have mental health nurses, physical health nurses, as well as even some paramedic staff starting to come through. Some of our staff have specialist interests in respiratory, end of life care. We also have band for assistant practitioners as well, all within our team. So we're a rapidly growing, rapidly expanding team with quite a lot of different resources within it. And we are open 8 o'clock in the morning till 8 p.m. in the evening, and that's 7 days a week. We have our referral and query hotline number on there, which is the mobile number on the bottom of the slide, and that will go through to one of our Band 7 nurses within the virtual hospital that can answer any questions and guide you through the referral process if you need assistance. Yeah, I think that's all I've got to say on that slide. I'm probably missing something, but there'll be time for questions a bit later on. One thing that I will actually bring to your attention now is that, like I say before, when the team were called the patient at home team, the referrals were slightly different. We do ask now, because they are leaving PAH and coming under EPUT, we do need that discharge summary to be completed on the ward before the patient leaves. And we also need them to be going home with a week worth of TTAs to include any flushes. And then we pick it up from there. And if the patient needs more, then we can order more later on. But the patient must go home with that first week. So here we've got just a couple of scenarios that we've been involved with to give you a little bit more of an oversight of what we can do. Although these do need a little bit of updating since the patient at home team have joined us. But for instance, we had a lady with Parkinson's disease who had hypotension. She was falling, likely because of her hypertension, and the fact that she had a lot of polypharmacy going on. So she was assessed by one of our rapid intervention service paramedic colleagues who identified the need for the virtual hospital. So she came under our care. She had a full holistic assessment, and we referred to the OTs within the team. We took blood samples because she had some UTI symptoms. We treated her with antibiotics. We reviewed her polypharmacy, and I think we took 2 or 3 of her medications off to help with that blood pressure issue. And then we worked in collaboration with the GP, and we made him aware what we'd done, what changes we'd done, just to make her more safer to be staying at home and stable for discharge. If we go on to the next slide. Yeah, so this is another scenario, a 75-year-old man that was taken to A&E, recently diagnosed heart failure. And we supported an early discharge from A&E for this gentleman to input with the heart failure medication, to monitor the bloods and to titrate their medications just to optimise his care. Yeah, and doctor was delivered to him, so he'd done the remote monitoring at home. If we go on to the next page, please. So we're getting quite a lot of positive feedback from all service users and stakeholders. So this lady, this was actually part of a newspaper article that we done actually, but she was onboarded to the remote monitoring after she was discharged from hospital after a stay with community-acquired pneumonia, but she was still not quite well when she came home. So the GP recognised this and he referred to us. And I think in the end, we had to give her some more antibiotics, and we monitored her and made sure that she improved and got much more back to her baseline. But she was very happy with the service. And she said there that she felt very safe knowing that there was always someone she could talk to if there was any concern. So like I say, between 8 in the morning, 8 in the evening, we're around. Patients on the remote monitoring side, they have a direct access to us. When they're provided with the equipment, they're also given a mobile phone or a tablet so that they can put the results on. Sometimes carers and family members get involved with the technology if they're not quite so sure, but doctor themselves are also supportive, and if need be, they'll phone call the patient when it's time to take their obs and talk them through it and take the observations from them over the telephone. But through them little devices that we do give, they're able to message in to the nurses who are monitoring the dashboard. And that's how we can do the video consultations as well, through them little mobile phones and tablets. So they've got a lot of access to us, and they get phone called almost daily as well by one of the senior nurses. If we go on to the next page. So some more stakeholder feedback, and generally the consensus is that GPs particular are finding us quite helpful. From the specialist nurses in the community, it's another kind of safety layer for them, so they know that they can implement a treatment, refer to us, and we will monitor the effects of that treatment and work alongside them to optimise patients' care. If we go on to the next page. Okay, so this is slightly different to the virtual hospital, but alongside us, we have our urgent community response. So this is more about prevention of admission rather than the supported discharge. So we have nurses and OTs who are able to go out and assess a patient within 2 hours of referral, to make a new diagnosis and implement any care that a patient might need to try and prevent them from coming in to PAH in the first place. If we go on to the next page, I believe we've got a little bit about our falls car. Yeah. So the falls car came into place from the 1st of June. So that's one of our very new parts of the service. Currently, we only have one falls car serving the whole of the West Essex localities, but we may be expanding that to include at least another one later on down the line. But again, these are patients that have fallen, that may not particularly have any injury, or they don't have an injury that requires A&E, and it's run by a paramedic and an OT, so they'll pick up the call, whether it's come from 999 or a telephone call from a GP or a HCP or a family member. They'll triage it, they'll go out and they'll assess the patient. We can pick them up and again assess them at home, treat them, and refer into other services as needed wherever it's appropriate for the patient. So if we go on to the next slide, please. Oh, that's it. So I have really whisked through that, and I'm sure there are more questions and things that I may have missed out, but that's just a brief kind of overview. We are a rapidly adapting and changing service, and there's still a lot of work in progress. So at this point, does anyone have any questions? Is there anything I've not answered or made clear that anyone would like to ask? No? Okay. So I think just to reiterate from your side, if you would like to refer a patient into the virtual hospital, by all means, give us a phone call on that mobile number, which was on the slide earlier on. Our referral form is on the intranet as well, so you can fill out one of them, and that will come through to one of our nurses who will then triage the call alongside the doctors. Our doctors do a lot of in-reach. Generally, throughout the week, one of our staff members will be over at PAH to be assessing patients to help that supported discharge as well, to bring them out a little bit quicker. But yeah, once we've accepted the patient, once we know that the TTAs are in place, the discharge letter is done, that's when we can let you know that the patient is ready to go home, in order for you to actually be able to physically discharge that patient and free up the hospital beds. But yeah, if there's nothing else, I think I can stop there. Oh, there's a hand gone up.
Sorry, I'm really sorry because
Hello.
I joined late, so I do apologise. I've missed most of it, but yeah, I just wanted to ask one question. So who would be doing the discharge summary for the time that they're in the virtual hospital?
So from PAH, you'll have to do your own discharge summary before they come into the virtual hospital. And then once we've finished with our added input, we also then do a discharge letter ourselves that gets sent to the patient's GP. So PAH have to do their own one, unfortunately. I know when we had the patient at home team, we used to take that responsibility on. But now that we are two different trusts with two different governance systems, PAH do their discharge summary, then we pick it up, and then we do our own one to the GP.
Yeah. So the GP doesn't, the hospital doctor doesn't have to do the discharge summary from your service as
Not
well
from
as
our
the one.
service,
Right,
just from your
lovely.
service. And like I say, we've got our own consultants, ACPs. We're able to do our own discharge summaries from our service. Yeah.
Okay, thank you.
Claire, I think you've got your hand up.
Morning. Yeah, hi, thank you. I'm Claire and look after our anticoagulation patients here. So my query is just going to be about prescribing of that, because for us it feels like a bit of a downward turn in terms of working with patient at home when they were with the hospital. So you were saying that the hospital has to prescribe at least a week's worth of medication.
Yeah. Yeah,
And
currently that's as it is. Yeah.
yeah, and yet you working on a paper system to prescribe once they're at the virtual hospital. Is that right? How do you, because obviously it's all done electronically by JAC, but
Yeah.
you don't
Yeah.
have JAC.
No, we have our own pharmacists here, and I believe they may still have access to read-only JAC, so they can see what the hospital has prescribed and what's been sent to your pharmacy from your end. From our end, we have our own prescribers. So once the patient's gone home with their TTAs, we can then prescribe our own drug charts for the nurses to be able to go in and actually administer the medication.
So for our patients, you would be prescribing, your team are going to be prescribing their anticoagulants while they're under you, or will you still like to use our service? You know, these patients are registered with us normally for their monitoring. So it's just making sure these patients don't fall through the loop, and also that when you discharge, if your team have been doing their prescribing of their anticoagulation, that then we're then copied into that discharge so we know what they've had, because it's very important for us ongoing that we know what medications they've been prescribed if they've
Yeah,
been
of
looked after by
course.
another team. So it's just to make sure we can make sure that there's no
Yeah,
gaps there.
we
Philo's
do it.
great, and we do work with her
That's
a
it.
lot.
Yeah.
So
I was just
yeah,
about to say, because obviously Philo is part of our team, so any patients that needs prescribing, particularly anticoagulation, IV antibiotics, we do communicate quite well, I believe, with PAH. And I know that we have been communicating with the anticoagulation service about any medication changes and whatnot, and seeking your guidance going forward with them patients. So
yeah. So that's what
yeah,
I'd like to just encourage. Really, we keep that
yeah,
open, and that you can actually get your team to ask us as well if they need any help, because obviously we've got all their records of what they would normally have, etc. So it's
yeah.
just joining us up properly.
Absolutely. Like I say, Philo is our team, and we've got Deva. They are our team, but I will make sure that everyone's aware that we can always touch base with you.
Oh, brilliant. Thanks, Carla.
Okay, no problem. Belinda?
Hi, yeah. I just wanted to ask, would you be having access to Cosmic and to Jack?
So their work's in progress at the moment. We are currently in the process of getting access to the nerve centre. Alertive is coming. Cosmic, I think there's work going on in the background about getting us access to that, but no immediate plans as yet. Jack, like I was saying, our pharmacists, we've got two pharmacists, they've both got access to Jack. I believe that's staying. So we are in the process of getting all of these accesses sorted out, because it will make, patient journeys a lot more smoother when we can all see each other's systems and communicate a bit better together.
Okay, thank you. Yeah, because I know the community children's nurses have got access. So I just wondered if it was the same model.
Yeah,
Thank you.
yeah, we're working on it. Is there anyone else, any other questions or things that I need to clarify?
Could I just ask, if no one else has got any questions then? So the clinical responsibility for the plan of care, as it were, who does that sit under? Would it sit with yourselves once they're transferred?
Yeah, we have our own consultants here. We do like to know with regards to any follow-up plans, particularly if the patient's under any specialists. But ultimately, when they're under our care, we've got our own consultants, doctors, ACPs. So we're very much clinically responsible for the patient's care.
Okay, lovely. Thank you.
I think that might be it for the questions. So thank you very much, Carla. That's really interesting and helpful. And we'll
Love.
save the recording and upload to our YouTube and get that out as well.
Lovely. Okay, thank you, everyone. Thanks for your time.
Thank you.
Bye-bye.
Thanks. Thank you.
Can I ask one more question?